Well, hello, everybody. Thank you very much for joining us today. I'm Bob Perna with the Washington State Medical Association.
I'm Kathy Gibb. I'm with the State Hospital Association.
We appreciate you joining us today for our program on MACRA. It is certainly taking up a lot of our time and attention, so we appreciate your spending time with us. We're very pleased to have both Kevin Kennedy and John Bry from ECG Management Consultants presenting today. So very, very high expectations of a quality program. Just quick orientations. We've got snacks in the corner for you. As you come in, we have on the stage right side would be the WSMA's table of materials. On the right side, we have the Hospital Association's materials. There are agendas there for you. So again, restrooms just down the hall to your left, and can't miss them. Anything else you want to add?
I just want to thank these two gentlemen from ECG for offering this service for us to help us kind of wrap our heads around what's coming and what we're doing. So, but after this, we will also, Bob and myself will be available for contact and any questions around this topic.
And this has been a three-part exercise in joint educational programs that we've done with the Hospital Association. Kathy and I did a foundational webinar back in October. That's available on our website. We have today's event. And in December, there's a flyer on the back page, on the back tables there for a webinar that we're doing with CMS Region 10. Dr. Nancy Fisher, Chief Medical Officer, is going to do a 1-hour webinar on the final rules. So again, with that, we'll get out of the way.
Oh, I did just want to say that we are recording this audio and visual. So if there are questions, if you would please allow us to give you a microphone so that it can be caught for the recording.
Good point, thank you. And that will be archived so that any of your colleagues that were not able to join us today in person, that'll be available. So again, thank you.
Okay, great. Thanks, Kathy. Thanks, Bob. And thanks, everyone, for coming. I'm going to move that down a little bit and see if that helps. All right. So thanks, everyone, for making it down here to CTAC. We have certainly been doing a lot of work that's related to MACRA over the last few years, and so when we first started talking to Bob and Kathy about this, we were excited to share some of the information that we've put together in working with our clients around MACRA and what it might mean. So, guys, anything new? How's everyone feeling today? A little bit shell-shocked, huh? Healthcare is, boy, just when you get used to change at a certain pace or start adjusting to things happening, something hits you out of the blue. I do think it's going to be appropriate, given the events of last night, to spend a few minutes talking about that before we move ahead. We have not had much time to adjust our perspective in terms of what that means, but we do have some. And I'd be interested in hearing from folks from the audience, too. I do think that if we let that get out of control, we could probably spend the next 3.5 hours talking about what it might mean for healthcare. So we are going to try to cut that off at the 10 or 15 minute mark. But I do think that it is going to be important to put MACRA and the overall healthcare reform movement in some perspective after last night. Before we get into that, though, just real quickly, walking through the agenda for today. We're going to spend about 45 minutes with a MACRA overview. And lots of you have probably already done a lot of research and things like that, but we do want to sort of hit the high points and make people are on the same page about what this really means. So the impact on healthcare, the different participation tracks, how they're scored, all those sorts of things. It's at least worth touching on that, I think. We're going to spend about 45 minutes talking about some of the strategic considerations for how you think about your organizations, how you might think about positioning yourself in terms of the move towards value-based healthcare and how MACRA might fit into that. Take a quick break. We're going to talk about the quality incentive. A big chunk of money and incentives are tied around this, so we're going to do a little bit of a deeper dive into what that might mean. I'm going to walk through 4 different case studies of organizations that we worked with recently and how they're thinking about MACRA and what to do about the move to value-based healthcare. And we'll wrap up by talking about some of the resources and support that are available out there. We have a self-assessment tool. We want to walk you through that. WSMA and WSHA both have tools and support available too. So in terms of leaving you something to take home to your organizations, we want to do that. And of course, I have plenty of time for discussion at the end. Okay. So just real quickly, most of you know about ECG. We were founded in Seattle about 45 years ago. We have spread across the country. We now have 11 offices and about 250 consultants. Healthcare is all we do. We do strategy, finance, operations, and technology for folks like you. We work with medical groups, community hospitals, and major health systems. And because of that, we're very well abreast of all the trends in healthcare, and we've been keeping pretty busy with MACRA, with understanding what it means and doing deep dives into that to help our clients adjust their strategies where appropriate. My name is Kevin Kennedy. I've been with ECG for 25 years. I'm one of the senior partners. I'm the head of the Seattle office and on the board of directors. It's great to look around the room and see so many friends and colleagues and current and former clients. So it's really fun for me to come back to events like this and see a lot of folks. I do a lot of strategic planning work. I do a lot of hospital physician integration work, and lately a lot of work to help my clients transform themselves into organizations that are capable of succeeding in what's going to be a very different reimbursement environment. I also want to introduce John Bree. John Bree is a manager with ECG. He's been with us for several years. He was with Milliman before he joined us and did a lot of work with health plans. So I think he brings some unique perspective in terms of the intersection of the financing and delivery of healthcare as well. And so we're going to be your crew for today. So about last night. Still a little shell-shocked. I've got a son right now who's overseas. He's down in Argentina doing a semester abroad, and I've been getting messages from him all day, just basically saying, "What's going on up there? Or, what's the mood?" He said he's had at least 50 people come up to him today and say, "What happened last night? How are you guys feeling? Have you heard the news? What does this mean?" All those sorts of things. I think it's probably even magnified for someone living abroad than it is for us. But obviously, we have to adjust our thinking quite a bit, not only because of who's at the top of the ticket, but also because for the first time in 6 years, we're going to have a unified government that actually will be capable of passing laws. And so what might they actually do? So just a little bit of perspective on ACA generally and the political climate. Most of the controversy that you hear about the ACA and people wanting to repeal it and the things that aren't working and the things that make people uncomfortable have to do with the insurance regulations, the exchanges, the sorts of products that can be offered and the restrictions on those. Okay, that's where most of the controversy is. On the other hand, the other part of the ACA, the part that impacts us just as much as that first part, is around payment reform. And there is a broad political consensus that payment reform is a good idea. Okay, MACRA didn't pass by 51-49 with someone from out of town having to be flown in to vote. Okay, MACRA passed something like 90-10. Okay, it was not a close vote. Both sides of the aisle seem to agree that fee-for-service medicine for Medicare is not a good idea and that it needs to evolve. Okay, so let's just keep that in mind too. When people talk about repealing the ACA, that's a bit of a rallying cry for some folks. I don't know if they're going to repeal the payment reform parts of it because, like I said, there does seem to be a pretty strong consensus that that needs to happen. Okay, so personally, I don't think MACRA will be going away because of that. I'm a really poor prognosticator, though, so consider that to be merely informed speculation. But that's kind of where we are. The other thing that, the second half of what happened last night was having the Republicans in charge of both the Senate and the House kind of puts a further spotlight on what, as a party, they might do. Obviously, the president-elect was not very detailed about what he said he was going to replace the ACA with. On the other hand, Paul Ryan was pretty detailed in publishing a white paper about what he thought would happen. So we haven't had much time to prepare for this. It's a little extemporaneous, but I know, John, you had some time over the last 6 hours to at least read the white paper and have an opinion on that. Anything you want to share with us?
So Paul Ryan definitely is all in on this idea of changing the way that healthcare is paid for, and in his A Better Way white paper that he did, he talks about shifting payment toward value. He's very much in favor of that. It might be in slightly different ways than we've talked about it historically, but fundamentally he still wants to be pushing higher quality, higher value healthcare. One of the examples I was talking with Kevin about earlier is Paul Ryan very much feels that Medicare Advantage is a good path for the Medicare program. Well, under Medicare Advantage, the insurers are still adding quality incentives, doing shared savings programs, variants of of the various value-based programs going on today, and include a lot of the elements of MACRA. And a lot of the strategies that we'll be talking about are applicable for Medicare, for commercial, for Medicaid, for all programs that come about. So the exact form of how they might want to change healthcare, that this whole push toward value of increasing the quality of care, decreasing the cost is still going to be a fundamental core of how they want to push the payment for healthcare.
Thanks, John. Any other thoughts or comments? I know from talking to people in the preliminary mingling here that there were lots of opinions about what might happen. I think it's worth spending a few minutes on it, given the magnitude of what happened. Anyone have anything to volunteer?
So I know there's a lot of talk, transitioning from basically volume to value, but part of the issue, I think, so we're down in Yakima, one of the issues we have is access. So right now, right, wrong, and indifferent, people are getting in to see a physician, and then so you start transitioning from volume to value and decreasing the number of patients that are actually getting in. What's the push from like the government's perspective on that? And then also around, I mean, you look at these Medicare Advantage programs, I don't know about everybody else in this room, but we're getting contacted every week about some new process that we've got to get in place to validate payers' websites to make sure that our rosters are right on their websites, and additional forms we got to fill out and spreadsheets we've got to submit. So we've actually started opting out and not participating in some of them because the requirements across 90 payers is too onerous. So, what's the conversation around that about streamlining processes so not everything's falling on hospitals and healthcare providers, and then the volume piece, I guess, I don't know, that's the part that I'm curious about.
Great question. I'll take a stab at that a little bit. I think that that's one of the things actually that has been driving consolidation in healthcare, is that if you're big enough in a market to matter, then you can go to the payers and say, let's talk about doing it a different way. If you're not, obviously you're going to be somewhat at the mercy of the way they want to do it. As individuals, 90 different payers all making their same decisions. So that's part of what is not all of it, but that's a big part of what is behind it, is being big enough to matter as healthcare providers, being able to go to payers and impact the decisions that they make. So I don't have much to offer on that beside that, other than you have my sympathies. I know the operational difficulties that are coming downhill are making it harder and harder in an environment where the reimbursement isn't keeping pace. Any other thoughts or comments on last night before we dive into MACRA? Okay, very good. Let's do some diving. So John's going to kick us off with an overview of MACRA.
So at the core, what MACRA is part of a larger effort to move healthcare, to reform the way that healthcare is being paid for. It's kind of encapsulated in what used to be the triple aim, now it's the quadruple aim, improving access, reducing costs, increasing quality, and now also improving the provider satisfaction, adding that provider side to this. And so, the access is definitely a question that's come up in other meetings that I've had, but the goal of not only MACRA, but with all the different payment programs that commercial payers are pushing out, that managed Medicaid may be looking at in the future, it's all around this idea of transforming the way that everybody is being paid and how healthcare is financed. And then the big impetus with Medicare now is everybody knowing that the baby boomers are aging in, and that there are over 3.5 million people that are going to be joining Medicare every single year. And you can see here the numbers of people who's 65 and older is going to go almost double by 2030. And the payments for Medicare, if they don't change, are just going to be skyrocketing. And so it's an unsustainable trajectory. And so that's why they're trying to shift everything under MACRA. And so the idea over the last several years is they've been doing a bunch of little projects, doing the shared savings program, various little quality incentives, but now really bundling everything into one comprehensive program that's going to cover all providers, all Medicare, and really make a giant push to make a change. And MACRA is one in a long chain of reforms that CMS has been putting forward. Back when DRGs came in, totally changed the way that the inpatient side was paid for. MACRA now focusing on that professional side and reforming how that's getting paid. and historically, commercial payers do end up following where Medicare goes. And so that's one of the reasons why we wanted to talk about your organization's strategy, your practice's strategy, because MACRA is one little piece, and independent of what happened last night or what might happen, the push towards value is going to be hitting every payer, every group of patients that you're seeing. And so setting your strategy right at the beginning can allow you to do well under all these programs as they come and allow you to outperform the market. So starting to dive a little bit into the actual specifics with MACRA. So there are two different participation tracks within MACRA. This track one, the MIPS section, where this is going to hit most providers, 92, 93% of providers are going to be under this program. And what that does is it rolls a bunch of existing programs, PQRS, meaningful use, the value-based payment modifier, rolling them together into a single program, and then making adjustments to your reimbursement based on your performance in all of these categories compared to everybody else across the country. The second track, alternative payment models, the APMs, this hits a small sliver of organizations, and it's really meant for organizations that have made a very big push into various payment models in the past. So organizations that are doing track 2 of the shared savings program, doing bundled payments, have a large portion of their patient population who are already under value-based arrangements, under risk-bearing contracts. And so CMS wanted to incentivize those organizations to continue down that road. So they've created this second track where organizations get an automatic 5% bump on their reimbursement every single year for the next several years, in addition to the regular rate increases. So it's definitely a more financially beneficial direction to be going within MACRA, but it's much more challenging to qualify. On the timeline, I'll touch on some of the year one adjustments that came out from the final rule, but the two dates to remember is January 1st of 2019 is when your reimbursements will start changing. That's when CMS is going to adjust up or down your payment for professional services. The other date is January 1st, 2017, just a few weeks away. That's when they're going to start measuring your performance. Throughout all of this, your payments are going to be adjusted based on what you were doing 2 years prior. So there's always going to be that lag. And CMS is going to be providing interim reports to you throughout the year of where how you are performing in all the different categories, so you can start be planning during the year and have a good estimate of what it will look like when it comes. But the big story is that MACRA is coming in just a few weeks, and they're going to start measuring your performance then, so getting as far in advance of this is the most important piece. So within MIPS, what they have are 4 different incentive categories that they are going to be looking at, 3 of which are ones that they're currently doing. So the resource utilization, that's talking about the cost of care. They're already measuring the cost per beneficiary overall, the cost for various different episodes of care for specific inpatient or acute illnesses or acute episodes. They're measuring the cost of care at your organization and then comparing that to everybody else across the country. The quality incentive, this is the biggest piece. This is going to be worth a little over half of the available points in the first year, ramping down to match the cost of care in later years. But this is the PQRS program being wrapped up, where they're giving organizations the opportunity to pick the quality metrics that you want to be evaluated based on, and they're going to look at your performance on those measures, again, compared to everybody across the country, not compared to your local area or your state, but everybody. Advancing care information, that's the meaningful use program, exactly as it is today, and they're wrapping that up to being a quarter of the incentive for all of MACRA. The new kid on the block, that's the clinical performance improvement activities. So what CMS wants to do is they're trying to incentivize organizations to take on operational activities that they believe will start to improve the quality of care and reduce the cost, improve access. So what they've put out is a list of about 90 different activities that they want to see organizations start taking on. So some of it might be around telehealth to improve access, different ways of engaging patients. And so within that, I'll dive in a little more on the scoring of that. But the other piece that I want to highlight, these top two, you see the percentages. I say 0 growing to 30 and 50 shrinking down to 30. So in this first year, CMS understands that this is a big change for organizations. So they've said, we're not going to score you on the cost of care for this first year. Instead, we're going to load it higher on that quality side. But then over time, we're going to bring those together so that they're each worth 30% of the total incentive. Those first two categories, again, they're comparing you to everybody else across the country. Whereas these bottom two, it's just about, are you doing the activities that are necessary to meet those programs that they're putting forth? So that big new change of being compared to everybody in the country versus just your hospital compared to last year or your area, it's going to make it much more challenging for some organizations. So on the APM track, I was telling you it's much more challenging to qualify. So putting up here the eligibility being having a certified EHR. A lot of organizations have moved that way already. They're going to have quality measures that are comparable to MIPS, that PQRS program. But here's the big piece is that 25% of your Medicare revenue has to be coming from some of these alternative payment models, so bundled payments, track 2 of the shared savings. And that percentage, that 25, grows each year up to, I think, about 75%. And listing here a couple of the models that the advanced payment models that they are including as eligible. One important note, the Track 1 shared savings program, the upside only, does not count towards eligibility for APM, which was a disappointment for some organizations, but I'll touch in a minute about some of the modifications that they are making. So under MIPS, the concept I was mentioning, there's that 2-year lag from when they're measuring you to when they're going to change your reimbursement. But the overall, what they're going to end up doing is in 2019, they've set these bounds of 4% growing up to 9% adjustment amounts. So your organization, they'll look at your total scoring compared to everybody across the country, and if you're doing better than most, then you get a positive adjustment up to that 4% level. If you're doing worse than most, then you're going to potentially be losing down to that negative 4% level. The upper boxes, all of MACRA is meant to be budget neutral, and so what CMS acknowledges that there might be some large organizations getting a minus 4% and smaller organizations who are qualifying for that plus 4%. And so in order to make this all budget neutral, what they're allowing is that organizations that are at that highest performing level can earn up to 3 times more of that of a payment adjustment in order for the whole cost of the program to stay neutral. So the resource incentive, resource use, the total cost of care, they're going to be looking at a number of different categories. CMS is going to be calculating these numbers for you based off of claims data. They're going to attribute all patients to a provider or organization. So there are always going to be people who are in that negative incentive, because what they're going to do at the end of the year is everybody gets a total point score, and they're going to line everybody up across the country and set that threshold based on the median score of everybody, meaning there are always going to be organizations.
If everyone scored exactly the same, there'd be no winners and no losers.
Yes, that is true.
Just to clarify, I thought in the final rule that CMS is really lowered the bar in 2017.
Yeah, so I've,
You can submit just one measure and avoid the penalty. You won't qualify for any upside. But if that's the case, and the bar's been lowered on avoiding penalties, there won't be penalties to redistribute on the
right,
other
so,
side.
so I'll touch on that. I've got a info about all the adjustments that they're making for that first year, for that 2019 year, and I'll touch on that in just a minute. So the resource use, this is information that CMS is going to be calculating. They'll provide data back to you, but what they're going to be looking at is the total cost of care at your organization compared to everybody else. What is your spending per beneficiary? And they're going to be adjusting all of these. Yeah.
Was that not removed in the final rule?
So in the final rule for the first year, this is worth 0. But in year 2 and beyond, it still is going to count. Yeah, yeah. And then they're also going to be looking at these episode groups, and here are a couple examples of, for very specific acute cases, what is your average cost of care for those compared to everybody else? And within this, they're going to be doing an attribution model so that every patient gets assigned to some provider or some organization. And so an important aspect in this is that there may be patients where you are their primary care, but they're getting all their surgeries, in downtown somewhere else, where you will still be the provider that's getting that patient attributed to you. So there's incentive for you to be collaborating with those hospitals that are caring for your patients, the other providers in town that your patients are seeing.
John, I think it's also important to mention about this resource use incentive is that they're going to be collecting our data throughout the year and submitting it back to us as well.
Yeah.
And so even though it doesn't count, you'll be using that information. You can use that information to improve your practices over time.
Yeah, absolutely. And that's really what that part of what that change in that first year is understanding that this is very new for a lot of organizations who say, I know what the cost of care at my organization is, but now you're saying we're going to be looking at it for all their care. And so they are going to be providing reports back to you frequently of where do you sit, what do your costs look like, so that you're able to start adjusting your practices before that next year when it's going to start counting.
How does this apply to the specialists, especially in rural health clinic setting? The primary care are not affected by this yet. I'm a specialist, and so I'll be affected by the MACRA. So
Absolutely.
How does it work for me?
Yeah, so absolutely. So two topics you brought up. First, rural health clinics are exempt from MACRA. As it stands now, there's potential that in future years they'll roll those in. But yeah, rural health clinics currently are being exempt, and so they don't count in there. Specialists are absolutely part of MACRA, and so the cost of care that they're going to be attributing to you might be different than what a patient who's being attributed to a primary care physician is. The other piece that will impact that is how you have decided to participate in MACRA as either an individual provider versus being part of the overall organization, because you can choose to report as one entity, in which case they'll be attributing patients to that entity and measuring the cost of care versus being that individual provider where they're going to be looking at just you.
Thank you. Given that attribution is going to affect your performance, is there any constraints imposed on the patient for how they seek care if they're going to be attributed to you but getting care elsewhere?
Unfortunately, no. So that's one of those double-edged swords on the provider side, is that patients are still going to have the same access allowances that they have today, but the attribution is still going to be impacting. And so part of what's going to be important is that engagement with the patient about where they are seeking care in your referral patterns to either keeping them within your organization or to other practices that you have, that you collaborate with closely, so that you can be part of that care decision and part of the care plan.
Are you able to shed any light on the mechanism for that attribution?
So CMS has about a couple 100-page document around that attribution. A lot of it has to do with who sees the majority of your care, both from a visit count as well as a dollar perspective. And they have a whole cascading process around who sees the majority of your care, if there are multiple providers, who is seeing preventive care versus specialty care, who is the provider you saw most recently. So that's CMS has put that has that information out there, but it would be another 3-hour session just to dive through all that, and the actuaries put a lot of effort into figuring out how that works because they want to have every single patient attributed to somebody no matter what.
Hopefully this will be a quick question.
Yeah.
Are these measures from the cost and resource utilization performance domain risk adjusted?
Yes,
Or raw measures?
they will be risk adjusted.
I will have the same question when we get to quality domain.
Okay.
Thank you.
Yeah.
How would this change from an individual practitioner versus a group, large or small group practice?
So it's not going to change in concept, but what will happen is you'll just have more patients that you're going to be compared against. And so as the individual, you might have a smaller number of patients that are attributed to you versus if you are part of a group, there might be patients who otherwise wouldn't get attributed to you but would be attributed to the organization because of your affiliation within them. So there is potential that there will be a number of patients included in your group that otherwise wouldn't if you were just on your own. Is there one more? Okay. So on the quality incentive, there's one big benefit that CMS has given here, which is that they've given all of you the opportunity to pick what measures you want to be measured on, to be evaluated based on. So what they're requiring is that you pick at least 6 quality measures, and they've got a list of 250 measures, and they said you just need to pick any 6 within here with the caveats that one must be what they're calling cross-cutting, meaning it's applicable to any specialty. So an example of that is BMI at every visit. That should be done at every patient visit, no matter what the specialty is from CMS's perspective. And then the other is one has to be an outcomes-based measure, not just a process measure. So are you checking blood pressure at every visit being the process measure versus a measure of what percentage of your attributed patient population has their blood pressure under control. So that being the outcomes-based measure. So they are requiring that you have at least one of those. One of the other benefits that they have is if you have more than one outcomes-based or high-priority measures, as they're calling them, that you're able to report on, they'll give you bonus points on those. So even if you score less than the full points on any of the 6 that you've reported on, you can gain additional points to increase your performance there. And the way that they're going to be looking at your performance on the quality metrics is at the end of the year, they'll pull the results from every single provider that's reporting to them. They'll put out the benchmarks at every decile and assign a point to every single decile to every percentile that there is and give you that many points. So each of your 6 measures are worth up to 10 points each. And so if you are performing at the 55th percentile, you get 5.5 points. So the maximum being that 60-point score. Yeah.
So this might be just something from the draft rule, because I haven't read the final rule. But in the draft rule, that performance scoring.
In the draft rule, the performance scoring was done the same way as it is for hospital VBP, which is that you get the better of achievement or improvement points. So they do divide everything up into deciles, but let's say you started out really crummy and you got better, you might actually get more points for improving than you get for, having started 85 and staying at 85.
Right. So at this, it doesn't look at your historic performance. It's what is your current performance compared to everybody else.
I think in the rule it says it's going to be this achievement improvement, but it might be the second year because they might not have a baseline yet.
Okay.
But that's the precedent for value-based for hospitals.
Right.
It's in the draft rule someplace, it's 20,000 pages, but it's
Yeah.
fantastic read.
I got to see what that final rule, which is 2,000 so, printed out in a binder. It was quite impressive. Quality scores, risk adjusted. Not risk adjusted, sorry, yes. It's just the payment is risk adjusted, but the quality scores are what they are, not risk adjusted. Yeah. Yeah.
So as a large medical group with over 100 providers billing under 110, we've participated in PQRS under the group practice reporting option web interface mechanism. Looking at the final rule, it specifies that using the web interface for MIPS reporting, we will be held to 15 measures we won't be choosing. This is if I'm reading it correctly. It says you'll follow the same process for web interface in calendar year 2017. Here are the 15 measures. Can you confirm if that's been your read?
I can't confirm at this
Can't
point.
confirm or deny at this point?
Yeah.
Okay, and then I'm wondering again how they're going to do that if the maximum number of points in this is 60 based on 6 measures. If we're doing 15, if we're told we have to do 15, I'm just wondering how that's going to work.
So the maximum is 60 points, and if you're reporting more than that, they'll give you bonus points up to that maximum of 60.
Thank you.
Yeah. There's a...
And G-Pro performance, that those clinical quality measures are around 15 measures. And so I would just caution you to check that, was that the MSSP track 1? Because were you on the QPP website, checking that out? And if so, then it was probably a reference to the MSSP track 1 and those measures. So you probably only have 6, even if you're going to report as a group.
So I wanted to give a quick visual on that scoring. So as I was saying, you've got the line up your performance. So if you give any given metric, if you score 16%, which is the in that third decile, you're just over that break point, so you get 3 points versus 79% as your performance. You're at the 84th. Or you're at the 99th percentile, you get 9.5 points. The other thing that they've done is accounted for measures where you've got 100% performance being at the maybe 75th or 90th percentile. What they'll do is they'll cut off the maximum number of points that you can get on that measure. So that's one of the considerations that you'd want to take when you're figuring out which 6 measures you want to select. Is look historically at what have those benchmarks been, because CMS will put those out, and ones where the 90th percentile is up at that 100% point, you might be doing very well, but you're capped on the number of points that you'd be able to end up receiving.
When is the expected historical perspective pushed out to us so that we can do what you just said?
So they'll be providing reports, I know at least semi-annually, so in July and at the end of the year, of what your performance has been so far. I don't know what their reporting on the benchmark numbers will look like, but they have put out, historically, they've got their benchmarks every single year giving you that mean score and the standard deviation, so you can look at that as kind of a guide of what performance has looked like. Yeah. So the clinical performance incentive, this is the new kid on the block. This is the giving you points for taking action, doing some operational activities. And what they're setting up is 40 points is the maximum number that you can score under here. And they've all the activities have been put into either high or medium weight categories, where medium weight is worth 10 points, high weight's worth 20 points. And what they want you to do is do as many programs as you want to score up to that 40. So whether that be 4 of those medium programs, 2 high weight programs, or a combination, but they want you to take operational action on some of these activities in order to score these points. And these are scored as either you're doing it or you're not. So you're either getting the 10 points for working on a medium weight program, or you're not working on it and you get 0. And I've given you a couple examples of the types of programs, the categories of where they're, of the programs that they're looking at. So ways of expanding patient access through, are you taking steps to make same-day appointments, or are you increasing your after-hours availability? Patient engagement, this is another big push that they're going for. Are you actively creating care plans and monitoring those with patients? Are you giving tools to help them with their self-monitoring of their care? A couple over here that are proposed that are still being finalized, but they've got a list of 90 different activities you can choose from. Yep.
On a broader level, can you explain a little bit better how the attribution works? Because there seems to be attribution of the beneficiaries, attribution of the providers if you're doing a group reporting, and then the payment adjustment, because we're reporting across these categories either as an individual or as a group, and even as a group, like with meaningful use now, it's still individual level data, and the payment adjustment is at an individual level.
Mm-hmm.
But as it's got brought together, it's going to be at a group level, I assume?
So the measurement is still going to be done at that, or the data collection is going to be at that individual level. If you choose to report as a group, you'll be reporting one aggregate set of data that covers all providers, and then they will make adjustments to the reimbursement for everybody.
So what about providers that work at multiple organizations?
So providers who are different organizations, they'll either be reporting as part of one of those two groups or individually.
And the adjustment will affect both?
They'll affect all Part B billing for that provider for that one organization.
That one organization.
Based off the tax ID number, so the person who works in, so follow the training to the tax ID number is sometimes easier to follow.
Right, but the payment adjustments for meaningful use now don't just apply to that.
Exactly. That's the problem. So meaningful use used to be just based on NPI, and now that we're merging the programs together, now it's NPI and tax identification numbers together.
Mm-hmm.
So it's taking what used to be and making a completely different penalty program.
There'll definitely be those little hiccups diving into it of trying to figure out how you were working on it before and what it'll look like once this is active and going. But the intention is to try and minimize the overlap of work that you have to do with all the different programs and bring them together into a single unified program. The last piece, this advancing care information, this is just the current meaningful use program as it is now, where you can score up to 100 points. And the way they're splitting those 100 points into a base of either you're submitting data, yes or no, and you get 50 points if you are, you get 0 if you're not submitting data. And if you are submitting data, then they're going to score you up to 80 points for 8 different measures of how you are doing compared to everybody else. So very similar to the quality incentive. So they're giving you lots of opportunity to score up to that 100 points. So if you're participating in meaningful use now, you can get that base 50. And then you've got all these other measures where even if you don't score the full points on every single one of them, you can still get that full 50 points to get up to the maximum 100.
So on this part of it, it was previously based upon hospital-based status, which you had to have a 90% hospital-based status to fall into the requirements of reporting meaningful use as an eligible provider.
No, I want to start again
So-
so everybody can hear, I'm sorry.
It used to be set up as a hospital-based status where you had 90%. And now, from what I have read in the final rule, they've changed that to a 70% hospital-based status. Now, by our calculations at our hospital, that's pretty much going to eliminate our providers from the meaningful use side or the advancing care information side of things, but would be required to continue to report out on the rest of it? I mean, I'm not understanding how they're gonna exclude all of the providers for meaningful use, it looks like, by the 70% threshold, hospital-based.
Do you mean the other incentive categories?
Yeah, the other categories.
So under that, they would adjust the total number of points that you would be eligible for. So rather than 100, eliminating out that one piece.
So, I mean, are they gonna do just a numerator denominator where you can just do 0 and it not count and not report on that category then?
I'd have to do a little more digging to understand exactly the nuances in that situation.
Okay.
So then take all of these programs together. What does this lead up to? So you take your quality incentive, all your reported measures, your scoring on all of those. You've got a 50% weight in that first year. Resource use, clinical practice, the advanced care, all those points added together based on the weight, and then they'll give you a composite score. So in this example, we've got that 0% weight on the resource use, representing that first year where it's going to have 0. This organization had 73.6 points out of the 90 that's available to them. Then what they're going to do is line up your score to everybody else's, and how does that compare? And they're going to set then a performance threshold, retrospectively looking at how did everybody do. Organizations that are above that threshold have more points, are going to get the positive adjustment. If you're below that, you're going to get that negative adjustment. So talking about the adjustments in year one. So for the 2019 payment year, 2017 performance year, what they're doing is setting that performance threshold at only 3 points. They're setting it very low. The intention is that they want to, they understand this is a big change, so they want to minimize the risk of organizations getting a negative adjustment. And so they've said that if you report at least one quality measure at some point during the year, you get those 3 points. And so you're guaranteed no negative adjustment. I'll dive to that second item, the participation timeline. So that's one of the options that they've given you is as long as you report something at some point during 2017, you're guaranteed that you won't get a negative, but you won't get a positive adjustment. They've also said that if you can report for any consecutive 90-day period, that guarantees that you won't get a negative adjustment, and you still have opportunity to get a positive adjustment, but just not up to that full 4%. So it would just be a couple percent depending on how much of the year you did report for. The exclusion criteria, this is another piece that they adjusted, although it doesn't affect a large population of organizations. They previously had set the minimum, the low volume threshold, so providers that bill Medicare less than $10,000 was the previous threshold level. Now they've increased that to 30. So if you do less than $30,000 worth of billing to Medicare or see less than 100 patient visits a year, then they'll exclude you from MACRA, and you'll just be getting the regular rate increases. We just talked about the participation timeline, the incentive categories. Previously, the cost of care was worth a few percent, but they've dialed that down to 0 for this first year. They'll be giving you back information throughout the year, but they won't be, it won't be impacting your score or your adjustment. And as I was saying, that performance threshold, 3 points will be that baseline threshold where you're guaranteed is 0. They've also set that exceptional threshold, so that top line at 70 points. So if you score more than 70 of the 90 available points, you'll be eligible for that increased adjustment. The amount of that will depend, it's up to 12%, and it'll depend on what the other organizations do and how much funding there is for that. And then this is the other big piece that people are interested in. Track 1 of the shared savings program does not qualify for,
No, finish your point.
Track 1 does not qualify for the APM, but they are going to create a Track 1 Plus. So between that Track 1 and 2, so the idea with the Track 1 Plus is that it's substantially the same as the Track 1 MSSP, which is just upside only adjustment, but they're going to add a little bit of downside adjustment with that. So rather than being the full Track 2 where you have the full negative risk, they're going to cap your negative risk at just a little bit. And if you transition from the shared savings Track 1 to the 1 plus, and you meet the other volume requirements of the percent of your patients that are under these programs, then you can then qualify for APM.
Just one point on the exclusion criteria. CMS, in some of its educational materials, was incorrect in stating that it was in billed charges. It's actually in Medicare allowed charges. So just
Right.
that distinction.
Yes.
If it does, then what happens if you have multiple practitioners in one group, some who are above the line and some who are below?
Yeah, so it does apply at the individual level, and if you have some that meet that, they'll be included in your reporting and the payment adjustment for MACRA. The other providers won't be part of MACRA, and you don't have to submit data based on their patient population. And then, as they were mentioning at the start, the December 14th webinar, Dr. Fisher will be here and doing another deeper dive into some of these year one adjustments and talking about kind of the concepts of why they're making these adjustments and what their goal out of changing these thresholds in order to ease that transition. But they have said that starting year 2, they'll go back to the full program where you don't have these multiple participation timelines. In year 2, you're either in Track 1 full MIPS for the full year, or you're in APMs for the full year. And if you don't participate in any of that, they're guaranteeing you the maximum negative adjustment. If you don't report any data, but you still have to fall into one of those two programs. So I wanted to give you just a quick set of calculations to start looking at what the financial implications of MACRA are, both positive and the negative risk. So we've put out here kind of a generic large medical group of 100 physicians doing almost 48 million professional charges, assuming that about 30% of that being Medicare, at 14 million. So that means that in that first year, a little over $500,000, almost $600,000 is the amount that you stand to potentially gain out of MIPS, or potentially lose if you don't participate or you don't pay any attention and score quite poorly. That can go up to 1.7 million if there is that exceptional performance. And again, that then grows from almost 600,000, exact same numbers, up to $1.25 million. So it's not a massive financial impact, but with organizations that are running just a couple percent operating margins, a loss of $1.25 million can really impact your financial health. And eventually that's going to transition down to the providers, the ability to pay for providers. This was a question kind of brought up earlier. So CMS acknowledges that a lot of this is going to be tough for those smaller practices, and they actually did an actuarial study where they were looking at what's the size of your practice versus the likelihood that you're going to receive a negative adjustment. And they are saying that those small practices, 1, 2, 3 provider practices, are going to unfortunately bear the burden on a lot of these negative adjustments, where over 80% of them are likely to be on that negative side because they don't have the IT infrastructure to do all the reporting. They don't have the coordination with other practices to manage the cost of care. They don't necessarily have a qualifying EHR that can allow them to meet the meaningful use. But the larger organizations that have built up that infrastructure and who have built up those capabilities are less likely to receive those negative adjustments and instead get those positive reimbursement adjustments. Now, this is not to say that those smaller groups are doomed under this program. The real story is that proactive planning to build those capabilities, to partner with other organizations or other practices so that you can pool resources to do the reporting and do the care coordination that's needed, that's what's going to set you up to get the positive adjustments rather than the negatives. So a couple key takeaways from all of this. As we were saying at the beginning, MACRA is here to stay. We originally had this in here not thinking about last night's outcome, but in general, the change towards value is going to be here. MACRA, as it is, it's unlikely to change. It was supported widely, and the strategies that you put in place, these capabilities that you develop, that infrastructure is going to be beneficial beyond just Medicare, beyond MACRA. It can help you as commercial payers are approaching you, if managed Medicaid shifts that way, if more patients are going into Medicare Advantage and you're able to take on capitated or other risk arrangements with those Med Advantage plans, these capabilities are going to allow you to perform well and get a higher yield reimbursement. Assume that you're going to be in MIPS and start planning that way. APM is definitely a more financially beneficial model to be in. You get the higher reimbursement bumps, but it is much more difficult to qualify for them. And the decision to participate in APM and being part of those other models is a bigger organizational decision. And we should all be viewing MACRA as an opportunity to get that higher yield reimbursement, rather than looking at it as, man, this is more coming from the government and more ways to squeeze payment. That's just a recipe for you to actually live that out and get those negative reimbursements. Instead, looking at this as a way to transform your organization, build the capabilities that are needed to survive later on. Now, that's what's going to allow you to get those positive adjustments, get higher reimbursement than you would under the current fee-for-service world, where rates are going to just keep either stagnate while your expenses go up, or they might even start seeing downward trends. And then the last piece is that MACRA, doing well under MACRA, it's not just a primary care initiative. It's something that all the providers need to buy into, because cost of care is going to be impacted by your specialists and by the surgeons. But the coordination across all of those specialties to coordinate the care of a patient through their entire care delivery circle is going to be important. And so getting buy-in from everybody, and not just your primary care providers, will be necessary to do well. So any questions before we switch over?
So you said, like, with the APMs that 25% of your reimbursement had to come through that model to qualify. I guess you just on the track 1 or something.
It's that track 2. So they put out a whole bunch of different programs, and if you participate in those and have a high enough portion of your organization in those programs, then you can qualify. Professional fees.
So just professional fees.
Yeah, this is just for those professional fees.
Okay.
All right. Hand it back over to Kevin.
Thanks, John. So really the goal of this next section is to go back to look at the chart of where we expect folks to land. And if you're in a smaller practice, obviously this isn't very welcome news, that more than half of the folks in practices with fewer than 25 providers are expected to take a hit under MACRA. Okay, so this next section is about thinking about your strategy, because there are things that you can do even as a smaller practice to help make sure that you're in that half that doesn't take the hit. Okay. Question in the back.
Are there resources for these small practices that, because you're looking at a practice who, under meaningful use last year, got a 2% reduction, and I don't know, let's call it $2,000, and then putting in a $10,000 EMR. Are there resources to kind of bridge that gap for them?
We're going to talk about that later in the session. Actually, we have a value-based self-assessment that can help you sort of figure out where you are and where you need to go, because honestly, we're fully aware that this can seem really daunting, right? How do we kind of throw everything we know out the window and start over in terms of how we provide care, how we think about care, and how we improve revenue and manage expenses. So it can be really daunting, and so our self-assessment kind of gives you a way to break it down into a couple of key domains, understand sort of what those components are, score yourself, or in terms of where you are versus where you need to be, and break it down into smaller actionable pieces. So that's coming up later in the show.
And the other piece I was going to add on to that is that CMS is going to be making a pot of money available to organizations to help fund some of those activities, but the details on that are still to be found.
Yeah, the details will be really important because if they continue to fund the rich, if they can afford, even in that category, then they miss the mark.
Yeah, although it does seem clear, and not only from this chart, but from lots of other steps that CMS has taken, that CMS likes consolidation, right? They're encouraging it. They're forcing hospitals and physicians to come together. They're forcing independent physicians to come together into larger and larger organizations. They see that as a source of efficiency. So, and in this industry, it's hard to fight CMS. It just is. All right, so there's not much humor to be found in MACRA, but there's an awful lot of work to do with this and with other value-based transformations. You may not be able to see the punchline here, but something we hear from our clients sometimes, we're hoping you'll lead us on a journey of transformation without requiring any real changes. So no, there's going to be a lot of changes. What we can do and what I hope you get out of this presentation is to find a way to make those as simple and as painless as possible, but it does require an awful lot of change. And not just from Medicare, from everyone eventually, okay? Medicaid reform is coming to the state of Washington. We know they've received some grants to make that happen. It is already well underway in many other states. Washington is probably middle of the pack in terms of where it is in its thinking. We have commercial payers that in this state have been probably a little behind the curve. I know I've talked to executives at local health plans who say they're excited about MACRA because they say things like, I can't make the physicians in my network or the hospitals in my network take 10% risk on quality, but I can ride in MACRA's coattails. Okay, when they're already making those investments, it becomes a lot easier to have those conversations. And actually, not only for health plans, but for you guys, it becomes in your interest to do that, right? Because you are making those investments that may drive down other revenue streams. You might as well be in a position to capitalize on them. So a couple things. This is a time of great uncertainty, right? And more so right now than it was even 24 hours ago. But we do believe, and we think we can make a pretty strong case, that reimbursement is moving from volume to value for both government and commercial payers. Okay, so not only do you need to be cognizant of the payers that you know about, but we have a new market entrant, right? Kaiser is coming to town, and ask the folks in Northern California how they feel about competing against Kaiser. Okay. Kaiser is dominating down there. On the exchanges, off the exchanges, they are taking market share from everyone because they have made these huge investments in providing care in a very different sort of way. Okay, so it's Kaiser and everyone else. And every year, Kaiser's getting another point or two of market share. Okay, we don't know what's going to happen when they come here, but we know they are going to be focused on making group health's product more competitive. And they will bring a tremendous body of knowledge from managing, hundreds of millions of member months of care in a very strategic way to make their product more and more competitive. Okay, so everyone in the room needs to be aware of that. That's coming for sure. So we do think that reimbursement is going to change. There are probably lower cost options coming to market. There's a lot of innovation going on all around us. Who's seen the commercials for? Is it with that new primary care group that's coming to town, IOTA? Have you seen that, John? IOTA, yeah. IORA. They're here, very specialized, innovative, disruptive, designed to provide lower care than most of us can provide in our organization, specifically for high-risk Medicare beneficiaries. Okay, they think there's an opportunity there, and they're pursuing it. And there are a lot of other innovative companies out there right now, who are striving to produce low-cost, high-quality models with the aim of taking your patients away and taking care of them. So regardless of last night, regardless of what you think about what's happening in MACRA, the competitive environment is changing and we need to be ready for it. Also, when we have conversations with our clients, there's always a balanced sort of discussion around, I know I need to get ready for value-based care, but in the meantime, I need to grow. I need to maximize my revenue. I need to make investments to get volume. Are there other ancillaries I can add? So we kind of have, 1 foot in yesterday and 1 foot in tomorrow, or maybe more likely 1.5 foot in yesterday and maybe 1 toe in tomorrow. But I think I can make the case that time that's ahead of us to maximize those fee-for-service revenue strategies is shrinking. Okay, so the future is coming at us faster than it was even a few years ago. And the time for balanced strategies, I think, is rapidly becoming a time to just go ahead and let's get on with it. Let's get in the future and realize where we're going, make those investments, and figure out how to make the best of it. So anytime an organization anytime an industry is evolving like this, it's very disruptive. It's transformative. It's very painful. Think about an organization like BlackBerry. Okay, who has a BlackBerry? 5 years ago, probably 3/4 of you had a BlackBerry, right? They couldn't keep up with the transformation that hit their industry. They were very slow to evolve. Other new entrants came in and basically ate their lunch, and now they're kind of a punchline. Okay, think about an organization like Netflix. Okay, who subscribes to Netflix in the room? Okay, well over half of you. When did they do their transformation? It was about 5 years ago, where they said, we're still going to do the DVDs by mail, but we're all about streaming now. Okay, and remember, they were going to call it Quick Flicks or something like that. They took sort of a tentative step into, we're going to transform this way, and everyone laughed at them, and their stock price tanked, and they made a really quick course correction to clarify what they were doing. And you know what? All of your organizations are going to make mistakes like that. You're going to make a mistake where I thought it was going here, and I ran over there, and it didn't happen. But the important thing was that Netflix made that correction really quickly, clarified their strategy, and said, we're making a bet on the future. Okay, we think media in the future is going to be streaming. We're a streaming company. We're walking away from this incredibly profitable DVD business. We're de-emphasizing it. We're not advertising it. We're not pushing it. We're going to drag people into the future. And they did it, and they've been phenomenally successful. Okay, so in this room, there are healthcare organizations that are going to be the next BlackBerry, and there are some that are going to be the next Netflix. So we all have strategic choices to make about which one we want to be. But I do think that the time frame for making those choices is shrinking. It's shrinking fast. To be competitive, costs have to be taken out of the system. Okay, you can look at sort of the international benchmarks, the charts you've all seen, things like that. We're not getting the value from our healthcare dollar that we should be getting compared with what we see in other countries. Eventually, the innovation in other countries and the way of doing things is going to make our way to our markets and to our patients and to our other customers. Question?
Yeah, I did have a question. I know I always get a little bit irritated by the statement. You hear it everywhere, volume to value, where I think MIPS in particular stuff is still adjustments to the payment for the widgets. Mm-hmm. It seems like a lot of the barrier to true care transformation are the things that are not covered services, mm-hmm. Are not paid for right now. If they were paid for, it may reduce payment other ways. And don't really see how, the MACRA approach and things like that really resolves those issues. Mm-hmm, it seems mm-hmm. like it still, does work within the various silos of payment, but doesn't get to the true root of what we really need to transform care.
Sure.
And, you mentioned, Kaiser and Group Health and things where, because of their payment model, they've had more flexibility to work within it. It doesn't appear that the government is really inclined to do that for individual providers in which it pays, more or less directly for those services. I was curious your comment on that.
Yeah, it's built into the system. It's been de-emphasized, certainly in the first year. Let's see, John, I'm looking for the slide on the resource. Oh, there it is. There it is. Resource utilization. They're starting small, right? This is where you cut costs. This is where you think about utilization per member, right? Per Medicare, and really that you're taking care of based on your Medicare claims experience. They're starting small. 0, doesn't get any smaller than that, because they know it's going to be controversial, it's going to be hard to measure, it's going to be hard for people to get their brain around it. But eventually, 30% of your score is going to be based on your cost profile. Okay, so yes, still fee for service, still making money based on widgets, on how many you can make, but you're going to make less money per widget if you don't do it in a cost-effective manner. So that's one way in which they're trying to get to it.
And then another piece that I would put out there is one of the benefits of getting those positive adjustments, spending that extra time if you are allowing providers to do those longer visits to manage more complex patients, or bringing on services, those wraparound services that might not be profitable on their own right or might not be reimbursed whatsoever, performing well under MIPS, or if you qualify for APMs, getting those positive adjustments is how you're going to then be able to fund those programs and fund those extra services for patients that really drives the value versus the volume.
That's right. A great point, John. We do think that part of this transformation does involve new care models. Okay, the model of a physician doing everything that a set of enrollees or a patient population needs has to evolve, and has to evolve quickly. Okay, physicians are too scarce of a resource, and they're too expensive. So we do think there'll be new care models that span, not just the continuum of care within your exam room, but across the real continuum of care that patients actually experience as they move through the health system. And finally, consolidation, like we just talked about, is going to continue. Okay, we're still doing a lot of consolidation work as a firm, even though it does seem like the work's getting a little more difficult, that most of the easy consolidation has happened. So it's getting harder to do it, but we are absolutely still seeing that as a trend that's going to continue.
So with that, are you guys seeing any dialogue on, if you look at like Salter Medical Group in Boise, where CMS is pushing for consolidation, but then you have attorney generals and other people like, with antitrust. I mean, how do you balance that piece? I mean, you kind of look at the same thing where there's this push of reducing inappropriate ER usage, but then EMTALA requires you, if they walk in the door, you can't. So there's all these like competing governmental regulations that contradict each other. Is there, at some point, are you guys hearing, or is there any thought nationally that there's going to be some dialogue to say, okay, we need to look at these things, or basically undermining everything we're trying to accomplish?
Great point, especially if your point is that the government is being a little schizophrenic and setting up catch-22s. No argument from me. We've absolutely seen that. We've had deals that we're working on get challenged by the FTC, and that's a really painful process to go through when that deal does get challenged, because you're essentially frozen in place while they conduct an investigation that may never end, literally may never end. They have infinite right to extend their investigation by 90 days at a time, and if you're stuck there in limbo, it's a lot easier to back out of that deal. So we're seeing more enforcement activity. At the same time, there's a stronger and stronger incentive to do it. So it's a tough one, no doubt. So some things to think about as you think about how to position yourself for this evolution is understand your readiness and your organizational infrastructure. Okay, are you actually ready to do this? Do you have the capabilities to do it? Who's on point for it? Do you have a team? Is it just you? There's an element of the organizational foundation and operations, and obviously for really small practices, it's a very different discussion than it is for medium-sized or larger practices. But even to the point of like, how do you make decisions? Is it clear how the organization makes decisions? Who's in charge? Who's accountable for doing these things? Without a pretty high-functioning organizational foundation to make these changes, you're going to be at a huge disadvantage. What does a network alignment and physician alignment approach need to look like? Okay, this is for the folks in the room who run hospitals. Being aligned with your physicians around this is absolutely critical. You won't make progress without them. And for the physicians in the room, you've probably already been approached by your local hospitals about being part of a local health system. So think about your place in that continuum. We do think that incentives matter, and your physician compensation arrangements will need to evolve to make sure that nothing sends a stronger message than having an incentive plan that reflects organizational objectives. And the population health capabilities, which probably seem like an abstraction, hopefully they won't after we go through this, are going to be an important new capability, just as important as how you manage other aspects of your practice. And for most of your organizations, that will be new. So how do we think about, we sometimes think about the value-based food chain and how organizations might evolve from fee-for-service towards something that is, that really does push risk down to the organization. So think about how your organization, might evolve and where you are now. Most organizations have at least some pay for performance, some sort of incentives. I know in this market, 5, 7 years ago, the health plan started pushing some money into pay-for-performance criteria, like generic utilization around pharmaceuticals, things that were pretty easy to measure and that could drive a lot of cost savings. So most of you are probably doing that. We're starting to see more interest in sort of a thin capitation, PM payment of cap to a primary care physician for doing some care management. Bundle payments continue to be an exception rather than the rule, but I'll tell you within ECG, it's one of our fastest growing practices, is the folks in our company who do bundle payments. We're starting to see some very good results in bundle payments. No question Medicare thinks this is going to be part of its driver. It's announced a lot of major initiatives in bundle payments. Ultimately, we see those being picked up by the states as well. Okay, so a lot of states that are reforming Medicaid are doing it through bundle payments, and that's happening right now. There are total cost of care or shared savings or risk programs that are out there. Probably the one that's gotten the most traction, the most traction out there is Premera's Global Outcomes contract that they've had in this market for the last 3 or 4 years. Essentially a shared savings program. If you do well, you get a bonus. If you don't, you don't. You may even take some money away. And the more advanced models around, a global payment, a global capitation with performance risk and P4P, and global payment with true financial risk, where you actually own the capitation payment and are living and dying by that budget. Haven't seen too much of that yet. Those models still exist in California in a large degree, and a lot of people think they'll be coming back to this market pretty quickly. When you think about the care models, starting with where most of us are now, which is it's about volume. Right, it's about throughput. It's about scheduling patients to maximize what we can do for them. There's lots of gradations to get to a point where you're doing a true population health, like the real population health managers do. Okay, like again, a lot of folks in California, a lot of the high functioning IPAs and multi-specialty groups, and the Kaisers of the world. Also, too, we see a lot of interest in the intersection between financing and delivery. A lot of interesting partnerships happening between health systems and payers. Okay, the payers are worried too that the market is also might be moving away from them. Okay, the ones who aren't named Kaiser are concerned about Kaiser. Just like you should be concerned about your ability to be successful, they're concerned too. And so we're starting to see things more like joint venture partnerships between payers and health organizations as both sides seek to shore up their future and do a better job of managing through all these issues. So one thing you need to be cognizant of, though, is that if you transform care without fixing the financing mechanism, what you're really doing is you have payers who are getting some free rider benefits. Okay, and this happened to a client of ours, not in Washington State, but not too far away. Is that they saw this stuff coming when the ACA passed, right? And so they launched task forces and they got physicians involved and they worked really hard and they dropped their length of stay by 0.4 of a day in 6 months. Okay, pretty fast, pretty big improvement. Cost them a fortune. Okay. They didn't have the payment mechanisms aligned up behind them where they could actually do okay with that. The payers are sitting on the side of the fence going, this is great, you guys cost a lot less than you used to, and here's your fee-for-service payment, right? So you really need to think about working both sides of those simultaneously, okay? So you can begin to see scenarios where it's in your organizational interest to embrace transformation, try to get it to happen faster. Right? You're making the investments, you're driving down the utilization, you should be in a position where you benefit from that reduction of costs as well. On the other hand, if you lead with payment transformation, okay, if you get those contracts, get P4P, get some risk, those sorts of things without transforming the care delivery, you're at risk. Right? You can potentially have downside risk or at a minimum not maximizing your revenue. So these really need to be in sync. And you need to think pretty methodically about those investments and how quickly you're going to go and not go too fast. Okay, so sometimes we think about this as kind of titrating the change. Okay, but with MACRA, we do think that fee-for-service Medicare is now in the value business. Okay, so it's hard to hide from fee-for-service Medicare. So we're all in this business now. Something to think about. So this kind of speaks to the key attributes for success. And when you look at the value-based assessment that we're going to share with you, broadly it looks like this. And the 5 key domains we think about are care delivery transformation. What sort of steps have you made to engage with your physicians to think about the way care is designed? Okay, and that is daunting. okay? Where do you start? Where do you start? Well, you start by having a conversation with physicians about where they think the opportunities are. You start with looking at your data to see where your opportunities are, where are the areas where your quality is not up to speed or where your cost is too high. You need to engage with physicians, obviously, to get them to own this problem. It won't happen without them. There are third-party resources that you can acquire in terms of bundles, in terms of protocols and things like that. But your physicians are going to want to have their fingerprints on that and make sure it fits their setting and your populations. So high-functioning organizations that start down this path typically find that after the first year, they have maybe half a dozen protocols done. Okay, that's not very many for a year's work. But 10 years from now, you'll probably have dozens and dozens of these, and that's exactly what that path looks like. Okay, organizations like Advocate in Chicago has been phenomenally successful with clinical integration, with taking risk. They're doing very, very well under those contracts and are expanding like crazy. After about 12 years of doing this, I think they're at about 60 protocols. Okay, but they started with 3. Okay, but you have to start somewhere. Recognize that this is going to be part of your future and basically a continuous work stream for probably the rest of your career. Robust technology. Okay, again, this is another factor driving consolidation, that there's too much work to do it manually. Okay, it has to be automated. You need to have the IT systems to help you get through it. If you're serious about taking risk, you have to think about what is your place in a comprehensive provider network. Okay, because purchasers of healthcare, payers, employers, the government, they're going to want to buy big chunks. They're not going to be as interested in buying whatever you're selling from your little silo. They're going to be interested in organizations that have population health capability, and that means they can take care of a patient across the entire continuum. Do you have provider compensation aligned? Okay, have you sent that message to your doctors that this stuff is important? That if your organization is going down a path that's value-based, your compensation plan needs to go there too. Again, do you have alignment around your payment models? Okay, can you actually do well by doing better if you make all these changes? Do you actually have payment mechanisms in place that won't bankrupt you? It's hard to think about doing all these things while making budget and making payroll, but that's exactly what you're being asked to do. And again, the organizational foundation for success. Do you have a sort of culture that is supportive of transformation, of doing things differently? If not, you may need to think about changing your culture. It's a hard thing to do. Do you have the organizational structure? Do you have sort of the right people in the right seats to go through this? Do you have the financial strength to do it? Most organizations find that there's an ROI to doing this, but there's a period of investment where things don't look so rosy before you come out of it. Okay. This issue alone has driven many providers to consolidation and think about joining something bigger because they don't think they have the resources to do it. And do you have leadership? Is your leadership committed to doing it too? Okay. So there's a lot of pretty fundamental things to think about when you think about your own value-based strategy and ultimately how that plays into MACRA. It's also helpful to think about, when you think about your payer strategy, it's not just a payer strategy, right? Because there are different markets. There are different markets that you play in and that the health plans play in. We haven't seen too much action in this market with self-funded employers, but certainly we've seen some, right, with the Boeing contract that came out a couple years ago. Rumblings about many more coming up. The state contract will be coming up, I think, in 2018 as well. They're acting like a big employer, which is what they are. Okay, so we're going to see more push to value coming from them as well. On the commercial side, not as much happening, but again, Kaiser's coming into the market as a disruptive force. I think that's going to change. Okay, the big health plans are going to have to do something different to compete with that. Medicare and Medicare Advantage is where a lot of our larger medical group and health systems start because it can be lucrative. It's a place where you can manage it and you can make money just because the dollars are so big, right? The PMPM associated with a Medicare beneficiary can be $700 or so, and so if you effectively manage that population, you can do pretty well. Medicaid too. Again, coming to Washington State. You've all seen the headlines. Depending where you are, if you're a small rural hospital that might have 50 or 60% Medicaid or even higher, that's really what you need to be thinking about. Okay, so depending on your situation, you may find one or more of these buckets are going to be more appealing to you and a better place to use your resources. Let's not forget about the commercial plans. We have seen, again, not too much action in the Washington state market, but certainly in other markets across the country, we have seen organizations like Aetna and Cigna and United that are copying a lot of the features of the governmental plans, including those in MACRA, and pushing those out to their networks. We're seeing a lot more activity with narrow networks. Okay, with health plans, finding the high-cost providers and just saying, no thanks. We're going to build a network around you so that we can drive the 10 or 15% differentiated premium that's necessary to grab market share. And again, let's not be surprised if those happen here too, because they're happening in other markets. They're happening right now. So let's think too about your ambulatory network. Okay, a lot of hospitals have made investments in their employed physicians, and a lot of them aren't really sure what to do with those investments and how it plays into it. And so the folks who are with independent medical groups, indulge me here for a second. This is more for the hospitals. But what we do find is that when those provider groups get to be about 75 or 100 doctors, they probably shouldn't be relying quite as much on the hospital infrastructure, which is how they almost all start. You can think about peeling that off into a separate infrastructure. At that point, you have the scale to operate more autonomously within that system and can do a better job with resources that are focused on ambulatory and really understand physician clinics. So I'm not going to walk through every aspect of it, but that's certainly a trend that we see, particularly with hospitals that are serious about getting into this business. You need to have a plan in place to think about cost reduction, and not only on the care delivery side, but also in terms of overhead. Right, a lot of organizations, we know that there's fat there. We know that we can do better. So these are some of the strategies that we've seen others adopt in terms of how to get those costs down. We're seeing a lot more action in automation, even in clinics. We're seeing kiosks. We're starting to see experimentation around mobile check-in, online appointment scheduling, and investments in business intelligence to help you make better decisions about how to provide care to your patients. On the clinical side, big investments in standardization, okay, clinical protocol development with the IT systems in place where you can track the physicians who are abiding by the protocols and those that aren't, and have systems in place to enforce that and reward it. And maximizing the care that needs to be provided to the right population. So again, being able to segment your populations among those who are really sick and need a lot of care, with the idea that ultimately you can reduce costs for them. So all these have lots of implications that spin off into lots of different areas. And again, specifically for the folks who are representing hospitals, we've seen an explosion of interest, again, in ambulatory surgery. Okay. For years and years and years, most of the business development work that we were asked to do for our clients was ultimately about how do we get more patients into the ORs, because that's where we make all of our money. Okay. That probably sounds familiar to the hospital folks in the room. Now, in a risk environment, in a value-based environment, it's not really the most profitable real estate anymore. It's the most expensive place in the hospital. So how do we keep patients out of there? Okay? And Medicare is absolutely going in this direction too. Every year, the list of ASC-approved procedures gets longer and longer. There are 10 new spine codes in 2016. Okay, this year, for comment, they put out the idea of doing total knees in ASCs. Commercial payers are already paying for that. Okay. The total knee proposal didn't get passed by CMS, just a matter of time, probably next year. Okay, so if you're a hospital and you don't have an ASC strategy, you really need to think about whether you're still going to be in the strategy in the surgery business in 3 or 4 years, because that's where most of the work is going to be done. So again, depending on your scale and where you are, you need to think pretty seriously about collaboration or partnership. Okay, smaller organizations are going to have a tough time with all of this. That's just a fact. You saw the chart from CMS. Basically, the smaller you are, the more this is going to cost you. So if you are still an independent organization after after all this time, after 20 years of consolidation we've seen in healthcare, well, first of all, congratulations. You have great staying power, and you were able to obviously do a lot of things right. But going forward, again, you need to think about your place in the continuum and your ability to survive. Okay? What we do when we're asked to think about, we get asked by organizations to help them answer the question, can I survive as an independent? And what we start with is we ask them to think about their vision of healthcare and their vision of what they want the organization to look like 5 years from now. okay? And maybe it means if you're a small group, maybe the vision is just, I just want to hold on to retirement, okay? If I can hold on until I retire, that's great. Or maybe it's, I've got 5 doctors in one location, but my vision is I really should open an office on the other side of town. I need to be at 10 doctors. Or if you're if you're a hospital, maybe it's I need to grow my physician network, or I need to build a new patient tower. Whatever that vision is, be clear about it, what it is, with whatever your governing organization is and among leadership. And then have a realistic look at your financial position and say, given everything we know about reimbursement, mostly going down, and what I know about expenses, mostly going up, do I have the financial wherewithal to realize my vision, okay? And smaller organizations many times find that they don't. So then it becomes, do I adjust my vision? Do I realize that I'm not going to achieve the dreams I had for my physicians or for my community or for my board? So I can either adjust my vision or I can go get some help, okay? And going to get some help is a big change, okay? If you're going to get absorbed by another organization, partner with another organization, whatever that answer is a really big change. But if you're going to go through it, obviously you want to pick a partner that's aligned with that vision that you have. Otherwise, go through it, right? We can find a way to fail on our own. If we're going to go and find a partner, let's find a way to succeed together. But consolidation is still happening. We're starting to see more innovative sort of partnerships, okay? Again, at the hospital level, more difficult models like joint operating agreements, service line joint ventures, things like that. For physicians, professional service agreements, employment obviously is still out there. Co-management agreements, there are ways to align with bigger partners that can help secure your future. And so you all need to be thinking about those things. I'm sure you are already. And of course, physicians are at the linchpin of all these changes, okay? Hospitals won't be able to do it without an engaged medical staff. Most of them have found they're not able to do it unless they have a fairly large portion of that medical staff that's employed, okay? And if you're an independent physician group, you can be in the middle of this, okay? And you should be in the middle of it. Physicians drive most of the cost. Physicians drive most of the quality. And so regardless of what your strategy is, it has to be built around physicians and their role in the care continuum. Again, this kind of speaks to some of those more elaborate alignment mechanisms that we're seeing between hospitals and physicians. There are sometimes very good reasons why physicians don't want to be employed by hospitals, okay? And I'm not the one to tell you that you should never, that you have to do that, because sometimes they're very good reasons. But there are other ways to align with hospitals and health systems that fall short of employment. And honestly, we're probably doing more work in those more creative areas than just I'm going to buy that doctor group now. So again, if your worry about being aligned with the health system is that you just don't ever see yourself as being a hospital employee, there are other options too that you might think about pursuing that can help secure your future, but also help maintain independence around those things that are most important to you. We talked about consolidation. It is certainly well underway. We did see a little spike in terms of merger and acquisition work right after the ACA. It slowed down just a tiny bit in 2016, but still consolidation underway. Not gonna belabor that point. So when we think about though, about the health system of the future, I mean, if you were going to design the health system of the future, and let's think about what that might look like, because that's exactly what these new entrants, these innovators, these disruptors are thinking about. They don't start with a hospital, right? They don't think let's build a patient tower and see where it goes from there. They think about primary care access points. They think about how do I build the population from the bottom up. And again, the folks who are serious about this are they begin at the bottom. They think about primary care, and they may contract with other parts of the organization to build that up and to design a system that's as efficient as it possibly can be. So let's think a little bit about the financial incentives within an organization that align with this. I've mentioned several times that this is going to be very difficult if you don't have physicians who are on the same page that the organization's on in terms of the value-based strategy and what needs to happen. So we do think that ultimately the compensation plan should support your strategy. okay? I think the best work we've ever done in terms of working with physicians around compensation plan follows on the heel of a strategic plan. That we now have the direction for the organization. Let's make sure our incentives line up with it. It should also support whatever care model you've come up with. Okay. Again, hopefully your care model is patient-centered, integrated, all those great things. More often, it will have mid-levels or advanced practice clinicians that are part of that care model. You need to make sure you set up incentives for collaboration to make sure that you can realize the vision of what that care team can provide. And ultimately, the compensation plan should, you need to be able to operationally support the commitments you're making to your doctors about how you're going to pay them. And that's also easier said than done. So what we typically suggest for folks who are thinking about that, about how do I evolve the way I'm paying my physicians, is that you maybe go a little slow, maybe a little more slowly than you'd like to. And most of us are evolving from a spot where we're around 100% production, where you're paying physicians for work RVUs, paying them to essentially be those widget factories, and run it faster and faster. It's kind of been the mantra for the last 10 or 15 years. But what we do suggest is introduce a new pool, a new part of that compensation plan that moves away from production. Okay, and it may be really small to start with. Okay, it may be, in fact, the first one of these I think we did was in 1993. I'd been with this company for only 1 or 2 years, and I think our sliver of compensation that was tied to something not production related was 3%. Okay, that plan is actually still in place, believe it or not, 20-something years later, and now that pool is up to about 20%. So every year they've added a little more to it. Along that time, they've gone through 2 different EMRs. Every time they do that, they get a little better at measuring things. They're investing a lot more in quality, that sort of thing. So there has been an explosion of data that's available over the last 5 or 7 years. And so compensation planning has gotten a lot more interesting. We have a lot more tools to play with now, a lot more data at our disposal. So you can really think strategically around what do I really want to have incentivized for my physicians? Because now you actually might have the data to do it. I mean, 20 years ago, we didn't have very good quality data. So it wasn't an option. Everyone thought quality was great, but we couldn't figure out how to measure it, didn't have the tools. Now we do. We're also seeing sort of a little mini trend for employed physicians back to base salary. Okay? Organizations are finding that building in a little bit of a base into their physician compensation gives the physicians a sense of security. It can minimize some of those variations in compensation that sometimes are driven by things that we don't like. Okay, so sometimes that physician who's at the 90th percentile in productivity, we really like the revenue, but is that physician really providing the best care, or is that physician just maybe seeing patients a little too quickly? So all those thoughts kind of go into thinking about what the compensation plan of the future might look like. So when you think about those non-productivity incentives, like I mentioned, they have increasingly gotten more sophisticated. Those first measures I talked about, the ones from 25 years ago, I think that little 2%, 3% incentive went to citizenship. Let's show up to meetings. Okay, show up at our quarterly meetings and you'll get the bonus. Relatively easy to measure. Not terribly sophisticated, and now that same plan, they're paying for outcomes at the specialty level. They are paying for panel size for primary care physicians, and they're looking at things like readmission rates and things that are really important across that care continuum, with a lot of work to do in between. I mean, things like patient satisfaction are now pretty routine. A lot of the things that you were measuring for meaningful use can be deployed. A lot of things you will be measuring for MACRA also make good candidates for physician incentives. And working through this stuff, of course, it's not really about the answer. It's also about the process you're going through with the physicians to get them on board, help support the organizational culture. We have found that for physician organizations that are going through this for the very first time, it can really be a catalyst to help form that culture in a direction that can be very healthy. And physicians will come to these meetings, right? They won't come to a lot of meetings, but when you're talking about their pay, they'll show up. So it's an opportunity to get them to listen and really engage them in dialogue. Okay. So you think about population health and what it really means. It can mean lots of different things, but a lot of organizations have thought about this sort of a 3-tiered model. And if you do this yourself, you may have 2 tiers, you may have 5 tiers. Everyone's a little bit different, but it's kind of an archetype. It's sometimes helpful to think about about different levels of risk within your patient population. Okay, with your high-risk patients getting basically a lot more care, right? A lot more attention. They may be assigned a personal health coach. They're getting a lot more phone calls. They're good candidates for remote monitoring, and being able to stratify patients into different tiers based on how much they might cost the system is something that most folks think is the future. Then in the middle, you have folks you might think of as rising risk. Okay, they're not getting quite the level of intervention that you are for your super high cost patients, the ones who are most at risk for showing up in the ED or for readmissions. But they are getting more care than the healthy population in sort of that low risk tier. Where in the low risk tier, those folks are more interested in access. They're more interested in a high level of service. Don't necessarily need the high touch. Okay, they may be more comfortable with an e-visit, with a video visit. They may want email access to their physician. They don't want to come park, right? They don't want to. They want the hassle of waiting in your room. They want quick hits in and out. Now, when those same patients get sick, we're looking at a team-based approach to care, okay? So maybe the mid-level is screening all the patients that come in, and the ones where the care plan is not obvious or where there is no care plan end up going to the physicians, okay? So again, folks like Kaiser and others who are very advanced in population health are starting to think about care with this sort of stratification. And the stratification is not easy, okay? Being able to tell these guys from these guys requires a lot of data and requires a lot of sophistication. And it probably doesn't sound like something that a small organization can do, right? I'm not going to go through every single one of these. And just so folks know, too, we are going to send you all these slides available, so don't feel like you have to write everything down. But for every one of these sort of care domains that we've talked about, there is a transition period. There's a spectrum here really of highly evolved all the way down to completely unevolved. And we do find that for the provider network, do you have a fully contracted network? Are you able to do direct to employer sort of thing? That's kind of the pinnacle of where folks want to be. For care delivery, do we have that sort of care coordination that I just talked about across all your patient populations? Most folks usually start with a limited patient population. They might start with diabetics, for example, okay, and do kind of a deeper dive into that high cost population. But eventually, you're gonna have to think about other elements of your population, how to set up similar models across that. And again, there aren't many organizations that can truly do that across all their patient population. But 5 years from now, there'll be a lot more that can, and you're more likely to be successful if you're part of one of those. Again, I'm going to skip through some of these because we are a little behind schedule, but those slides will be available. So I know I've given you maybe more than you wanted to think about in terms of the strategies that you might need to think about employing. But if there are any questions, I'll take some questions. If not, we'll move on with our break. All right, thanks everyone. It's next to my right, 15 minutes.